at the EVTM Symposium in Örebro. I'm standing here with Martin Delle, who's an interventional radiologist here in Sweden, and Frank Plani from South Africa, a trauma surgeon. Thank you for participating in this discussion. We've seen that endovascular methods for hemorrhage control is starting in the recent last years gain popularity and taken over a little bit from the open surgery. Frank, what role did these endovascular methods play in your institution in South Africa?
Yeah, I think it's we certainly, like the rest of the world, we started being bought over to more endovascular control since the EVTM last year in February 2017, which I think was quite a watershed moment in convincing more people about the usefulness of Reboa. So we feel that whenever it's possible, we'll even whether it's with blunt or penetrating trauma, we'll probably be able to essentially control the flow through the aorta with a method which has now been proven to be quite safe, thanks to the low profile sheaths and the small size Reboa catheters we can use. And I think we, if you can avoid an emergency thoracotomy, it's always good. The consequence of emergency thoracotomy are often underestimated. Very often people lose a lot of heat. They lose a lot of blood, particularly when you have to concentrate on the abdomen after you've done emergency thoracotomy. When you're in a damage control situation and you need to then do a partial closure of the chest, very often you actually leave bleeding behind after an emergency thoracotomy. So it's not so innocuous as people make it out to be.
Yeah.
And that's why I think having something endovascular is very welcome.
Martin, you're in your institute here in Sweden. You're an interventional radiologist.
Yeah.
What do you find that the EVTM and the endovascular resuscitation methods in trauma? How does that affect your institution? Are you involved in this?
Yes, we don't have that many cases because the trauma care is centralized to the Karolinska Solna. But we still have those emergency cases with GI bleedings and postpartum bleedings, where this technique is of course invaluable as a complement to surgery. So as interventional radiologists, I think we have a very, very important role to play. But during the last 5 years, there has been a lack of interventional radiologists. So we are now, during the last 2 years, we have the ambition to expand the team and also involve anesthesiologists and surgeons to complete the circle, so to say.
You're talking about this team, and I think that's very important. The EVTM, it's apart from the different endovascular techniques, Reboa, we have stenting, we have embolization, but also the EVTM stands for the multidisciplinary team, but in resuscitation. What part do you find that interventional radiologists play in this multidisciplinary group?
I think we have a lot of knowledge because we have those techniques, using all these techniques in an elective fashion. So we have the skills and we have the materials to do it. So our responsibility in this team building is to share this knowledge and educate younger colleagues, of course, but also colleagues from other specialities, so they become aware of that these techniques are available in the hospital. It's a large hospital, and also so that we get more interventional radiologists that can perform those procedures in an acute fashion.
Yeah. Frank, do you have in South Africa? Do you have interventional radiologists?
We do, but they're few and far between.
Okay.
And so basically, very sought after. They normally tend to gravitate in very few hospitals, and especially in the private sector.
Okay.
And therefore, it's actually the very rare commodity. So I think from that point of view, it would actually be very important for trauma surgeons to follow what's been mooted by a number of centers in the United States, not just doing the endovascular control of the aorta, but actually to be able to have access to stenting and to embolization. And at least in view of the fact that we've got a very good relationship with the we're also stretched vascular surgeons, we can actually at least mobilize the staff, identify the equipment we need open the operating theatre, start, and if necessary, then continue in the cooperation with the vascular surgeons, even in the absence of interventional radiologists, because a lot of intervention done by vascular surgeons in any case.
Martin, he mentioned, Frank just mentioned stenting and embolization also as techniques in endovascular resuscitation and the importance they play. What do you find as an interventional radiologist? How can we, at these EVTM and these sessions, we speak a lot about REBOA. Stenting and embolization doesn't have as much, is not talked about as much. Which role do you think they play? Is there more to do there?
Absolutely. I think it's important to see that it's not either or, because it's a complement to each other. I mean, a severely traumatized patient perhaps needs both open surgery as well as IR means to reach the goal. So I think it's that we have understand each other and don't compete. So in a team, one should realize when the patient needs the indications for open surgery and when the indication is ER. And that's a challenge because everybody wants to get first fingers on the patient and do the heroic things. But I think it's better to be a team and to find the indications for which is best for this special case.
Yeah. So these different methods of endovascular resuscitation. We have this multidisciplinary group with interventional radiologists, trauma surgeons, vascular surgeons, ER physicians. Everyone has their own expertise. There are different courses around the world in teaching endovascular resuscitation and the multidisciplinary approach and these procedures. We have the BEST course in America, ESTAR course, we have the EVTM course here in Europe and the DIRECT course in Japan. What do you think as an interventional radiologist, is it important to educate more people in this, and how should we educate these people in this multidisciplinary approach?
I think those courses you mentioned are really sources for inspiration. You meet colleagues and you can see the potential of these treatments. And I think also when it comes new techniques, new materials, it's important that you share that and you get to know about these techniques early, in an early stage, so you can use them by yourself. And my young residents, I really encourage to visit these courses, because when they come home, they're so eager to try it themselves, and they're really trembling of inspiration So I think that's a good source to get inspired.
What do you think, Frank? Is there a role for this for trauma surgeons from South Africa, or yeah?
Absolutely. I think it's it's so obvious that very often you'd like to embolize, probably more embolize than stent. I think stenting may be pushing it a bit in terms of the material required, ordering specific stents sometimes. But certainly embolization is something that sometimes it should really be done immediately, and you realize that you've gone so far, you just need to go that extra mile or the extra half a mile and be able to actually go past REBOA and do the embolization. And very often you're going to find that, as I said, you don't really probably need to do everything yourself from the beginning. Other people can come and help you. They're just not going to be there immediately when you need them at 3 o'clock in the morning, but they can come at 5 when the theatre's already been opened and the staff is ready. And so very often you're not talking about something which is really requires to be done immediately, but certainly in a very reasonable period of time.
So we just mentioned these courses and so in South Africa, for example, what does it look like? Who's involved in the trauma bay when a trauma patient, a bleeding patient, comes in? Yeah,
the situation is very different in different hospitals. I can only talk about the Kusani Baragwanath Academic Hospital, which is the biggest hospital in the Southern Hemisphere, and used to be the biggest hospital in the world until a few years ago. So the trauma unit does everything in basically within the trauma unit itself. The consultant is always there. We've got registrars, and we've got lots of people from all over the world that come out and help. And And clearly the idea that, particularly talking about new technologies and new ideas, the consultant must be, the specialist must be being the driving input. And so until now, all the reports have been done by trauma surgeons that are there on site 24/7. Sleeping room is about 5 meters away from the resuscitation room. Our office is about 2 meters away from the resuscitation room. So the idea that whenever you're on, you'll be able to intervene immediately. Otherwise, if you rely on, basically you cannot rely on trainees for technologies and techniques that have just been developed.
Absolutely, yeah. What role do you see, for example, nurses playing in this, or even other staff apart from doctors?
Yeah, I think nurses until now, and sound a bit facetious, but I mean until now, have just all the nurses just not to make any noise and let me work. But clearly the idea that while people are understanding how things work, it's very important that people watch how things are done, and by osmosis, they actually understood without having to be told on the spot, because you don't train in a disaster. You need to know exactly what to do in a disaster, and doing the reboa on your own for the first time probably is a bit of a disaster. So clearly, basically you need to prepare all the equipment you need. They need to know exactly where things are kept. And then slowly, by osmosis, they're actually learning what the function is in supporting the surgeon that's doing the reborn application. And they all become extremely enthusiastic because they've actually realized it's obviously the care for the patients, the care for patients, and they're actually seeing the difference between slashing open the chest and somebody just basically putting an injection in the groin and the patient's blood pressure going up to 120 from 40. So it's something, it's a feel-good technique in a way, and everybody can see it by looking at the monitor, and everybody can see in fact how reasonably simple it is. They don't need to know the intricacies of how tricky it may be to avoid causing arterial damage, but basically it's a technique that helps the patients, and that makes them very willing participants very soon.
That's great to hear. Martin, you must be used to having nurses that, especially, I mean, when it comes to endovascular devices, there's a whole loads of different catheters and so on, different balloons, different devices to be used. Your nurses are obviously way more familiar with all these different devices and know how to use them, and also know in which way you like to use them, and maybe even help to suggest different things.
Exactly.
How do you think that we can use their experience in the trauma bay, in the emergency department, where these trauma patients will be coming in, to get that experience also to these nurses?
I think that you have to give them the chance to learn how to act in an emergency room, and how to act in a hybrid room and in an OR. Most technicians, X-ray technicians, are used to the angio room, but they have to broaden their capacity so that they are familiar also with open surgery. So you can do a combined procedure, and they feel calm and comfortable with those procedures going on simultaneously. And also a skilled nurse also can give you, as a young doctor, good advice, exactly as you said, regarding catheters. Try this, don't try that, and so on. And if you come into trouble, 4 eyes are better than 2 eyes.
Absolutely.
So I think they have an extremely important role to play, and they should definitely take part in the education of these procedures.
I think you summarized it there pretty well. 4 eyes are always better than 2. You know, we help each other out, and I think that's the whole thing about this movement, the EVTM, the multidisciplinary approach. As to wrap this whole up, what do you, Frank, what do you see that? What is the future for EVTM as a trauma surgeon? How do you think? What is left to do? How should we develop it even further?
Yeah, I think EVTM is giving us new vision over on what can help patients in terms of essentially interrupting aortic blood flow, and it's shown us that very often what we've been taught, that we don't operate on, we don't do emergency thoracotomy of blunt trauma, There's no point in doing anything endovascular for people who had a massive heart attack, for instance. That really probably is not true, and we've seen with the interventions by Reboa that can actually help people with blunt trauma and even people with hemodynamic instability or hemodynamic collapse, not due to trauma at all. And we've seen it in the in some cases of medical cardiac arrest. We've seen some cases of obviously placenta and abnormalities and ruptured uteri. So clearly there are lots of things that are not really related to trauma where if you basically put something inside the aorta, it could be outside, but I mean basically Reboa is all about inside, you can actually help those patients. So clearly I think has opened our eyes as to the what the body needs, and basically you need to stop the blood flow. And the endovascular techniques are a very good way of doing that.
That's great. Martin, what do you think? What is the future for endovascular resuscitation?
I think we have met quite a great challenge, because we have added complexity to the traditional way of handling trauma with open surgery, and now we have more markers on our plate. So I think it's very important that we evaluate the outcome of the different techniques we now have in our toolbox and see to which patient should have which treatment. So we have to not only go on and think that EVTM is curing everything. We have to evaluate it and have studies and registries to see how good it is.
Really, okay.
Not only that we can do it, should we do it?
Absolutely. I think that's a very important question to ask. Okay, so I think that sums it up from Frank Plani from South Africa, a trauma surgeon, and Martin Delle from Stockholm, Sweden, an interventional radiologist. And I hope that has inspired people to have more interest in what endovascular resuscitation means for an interventional radiologist and a trauma surgeon.